heavy chain is very potent, and heavy chain is very selective on what type of vesicle it will attach itself or cut the SNAP25. So currently we know that it only modulates on pain, especially CPRT, substance P, and also it's worked very well with TRPV1 or Vineron type heat sensing receptors. So how to inject and where to inject? We can, with many studies for pain control, you can use it subcutaneously, you can use it intramuscularly, you can use it intradermal, and especially perineural and nerve block. You can use it everywhere, literally. And in animal studies, many inject into intrathecal and find they work very well with intrathecal in managing pain. But you cannot use it supraspinal. So there are a lot of animal studies injected into the brain, intracistern, and they find they have no effects on pain treatment. So it has to be injected from the spine downward in order to work as pain control. So this is the botulinum toxin and how it's worked if you look into pain pathway. So in this pain pathway, it's block TRPV1. It's also reduced the secretion of substance P, CPRT, and glutamate, which is the neurotransmitter for pain. It can be blocked peripheral side and it also blocks central side. So it's blocked those central sensitizations and block peripheral sensitization. So in terms of pain, it's doing a very good job in blocking pain signals. So ongoing with the studies, because we know that they know that in order to have pain, you have to have inflammations. And if you remember the pain pathway, you need inflammatory soup to produce this pain. So this one, they try to see if botulinum toxin can reduce inflammations, because if you reduce inflammations, of course, the pain will be reduced as well. So they have a rat, laboratory rats, and then induce a rat with knee pain and cause the arthritis of the knees of the rats. And then after a while, half of the rats got saline injections, the other half got botulinum toxin injections to the knee. You can find that, and they examine the knees for IBA1 and interleukin 1B, which is the markers for inflammations. They find that this is 1 week, this is 2 weeks, this is 1 week, and this is 2 weeks. Compared to saline injections, you can see that the activities of inflammatory marker is significantly less after 2 weeks when you got botulinum toxin injection into the rats. So they suggest that it might have something to do with inflammations for botulinum toxin. Then they study further for the regenerating of the nerve, because we nowadays we start injecting botulinum toxin around the nerve at perineural site. So this one they inject into rats as well, and then cut the rat's sciatic nerve. They induce it with formaldehyde to make it injuries, and then after 7 days and 10 days, they cut and they do some color dye. You can see that after 10 days, this is a saline, this is botulinum toxin. You can see that the lining of the sciatic nerve seems to improve with botulinum toxin groups, suggests that you can have some regeneration of the nerve with botulinum toxin. But in terms of clinical, because of this picture for me, it's still nothing. So this study also look at the clinical parts of the rat as well. So they put the rat into a walking test and see how it's bear weight. So this is a paw of a rat when you get salines and botulinum toxin at 10 days. You can see that the weight bearing is not quite good. And then after 14 days, the rats that get botulinum toxin injection to the paw, the walking and the weight bearing come back to a normal, you can see all the finger of the rats there. So they suggest that there have to be something with the regeneration of the nerve in order for the rats to recover compared with the placebo or the saline group. Then how it works with pain. So when we talk about pain, we have to go back to all these receptors. So of course they have to start with a very common receptor, which is GABA A receptors. So this is a very straightforward studies. They give the rats formalin to induce pain. And then they use bicuculines, which is the GABA A receptor antagonist. So when you give bicuculines into the rats, GABA A receptor is not functioning. So you can see that if you give them bicuculines, this is the lick test. Lick test means if they lick a lot, it means they are painful. If they lick less, it means they have less pain. So after it induces pain, botulinum toxin licking seems to be lower than other groups. But if you give them bicuculines, which blocks GABA A, the licking comes back to normal, which can mean that botulinum toxin also works at the GABA A receptor as well. Then mu receptors. Similar studies, but this time they do it in mu receptors because, of course, we talk about pain. GABA mu receptors, the very common receptors. This one they use naltrexone and induces pain to the rat as well. And then you can see that with botulinum toxin, after you induces pain, the pain was less in the botulinum toxin group. And then they inject naltrexone subcutaneous into this group of rats. The lick test or the pain came back, which means naltrexone can block the function of the pain reduction of botulinum toxin as well. And then after 24 hours, because botulinum toxin worked longer than naltrexone, the pain was become less again. So these studies, they confirm that they have to be something in correlation between botulinum toxin and mu receptors. This is human studies on glutamate release. 2 arms of the volunteers, 1 arm inject with botulinum toxin, the other with no botulinum toxin. And then they induce glutamate release with capsaicin patch. They put on capsaicin and then hope for glutamate release. Just a while after the capsaicin works, they dialyze the area and then get the fluids for examinations. They find that the glutamate release on the botulinum toxin side was significantly less compared to the non-botulinum toxin side, which means botulinum toxin can block glutamate. And also because it works at TRPV1 on the glutamates, on the botulinum toxin side, the skin temperature was lower than the capsaicin without botulinum toxin side as well. So to conclude with the mechanism of the botulinum toxin, at the peripheral side, you can inhibit neurotransmitter release and reduce peripheral sensitizations. At the axon side, you can promote Schwann cell proliferations and sort of help regenerate the nerve, and then block TRPV1 receptors at the post-synaptic parts. And then at the dorsal horn, you can sort of regulate the neuronal functions and then reduces pain. At the spinal side, it acts as opioids and it also acts as GABAergic systems to reduce central sensitizations. So this is all the basic mechanism of how it reduces pain. It's not just that it reduces acetylcholine and reduces muscle contractions, but it reduces pain in many other ways. So we will continue with clinical evidences for the pain treatment. So like I said, botulinum toxin, when it first used was pain. They used it with headache, and there was so many studies with headache and botulinum toxin. Mostly they use botulinum toxin as medications to be injected at the muscle around the occipital area of the head, and also around at the trigger point area of the muscle around the head to reduce the pain of the headache. So they studied, this is a meta-analysis long time ago, 2012, chronic migraine, chronic daily headaches, and chronic tension type headache. All type of headache improve significantly, and you can see the plots. It's all favor botulinum toxin injections. Then that's a part of inject into the muscle. But so go on with the toxin. We talk about neuropathic pain. This is a treatment on many types of neuropathic pains. So they inject it intradermally, and the studies is on post-traumatic patients, post-operative pain patients where we have sort of neuropathic pain or sensations at the skin, and also post-traumatic neuralgia, which is very troublesome for many patients. So they inject intradermally along the pain site and then wait a while. So after 2 weeks, the pain reduced significantly compared to placebo groups. And number needed to treat is around 3, which is quite good when you compare to other type of oral medications. The NNTs are a lot higher for neuropathic pain. For post-herpetic neuralgia, which we find a lot of positive neuralgia in senior patients, they tend not to tolerate well with oral medications. So this can be a better option or easy option for them because not have to go through oral medication. So this they compare to one group is get intradermal botulinum toxin injections, and the other one is the lidocaine injection intradermally, like standard treatment for post-herpetic neuralgia. So the study concludes that the group that use botulinum toxin has the least amount of patients have to convert to opioid use, and then visual score is less in the group that use botulinum toxin compared to placebo and compared to lidocaine injections. And in the meta-analysis, it's favor botulinum toxin if you compare to lidocaine alone. Then this past year, I'm very intrigued and I work a lot with trigeminal neuralgia. Trigeminal neuralgia is underrated disease. A lot of pain, and patients cannot eat, patients have to stop working, and a lot of tooth pain. So they cannot eat. Most of them have to stay home. So this past year, I worked with this type of patients a lot. So they started with intradermal injection as well to the skin. So along the painful area, B2 or B3 area, and then inject it dermally into the skin. This group study found that both pain intensities and pain frequency reduced significantly in 2 weeks after injections of botulinum toxin intradermally. And you might be afraid that the face will change. You might have one tight face and the other part is not tight, and the patients might not be happy. But in this group, they suggest that there's no change in face figure after the injection of the intradermal botulinum toxin. And then, what dose should we use for inject intradermal for the face? So this group they divided into 2 dosage and placebo, 25 and 75 unit of botulinum toxin scattered to the pain area. So they find that 25 or 75 unit of botulinum toxin provide similar amount of pain relief. So they're no different in pain relief in both dosage. So the lower the better. if you go back and read the function of how you inject botulinum toxin, actually when you inject botulinum toxin, most part will clear out lymphatic drainage. It's very fast that some part of botulinum toxin adhere to the affected side, the rest gone very fast. So that's why the lower dose, the better when you use botulinum toxin. But you just have to find the minimum dosage that can be used with each treatment. So this is the three combined meta-analysis for many types of neuropathies. Trigeminal neuralgia, diabetic polyneuropathy, and peripheral neuropathies, which has a lot of number. So all of them all favor the use of botulinum toxins intradermally on the painful site. And then after you do subgroup analysis, it still favor botulinum toxin after you get rid of all the bias. Again, because I work a lot with a lot of trigeminal neuralgia, many patients does not only come with face pain, they come with tooth pain as well. So in order to inject to the face and hope that it will reduce this pain at the tooth area, well, in theory, botulinum toxin will travel along the nerve, and it should travel inside the nerve as well. But why not inject it into the nerve that feeds the tube in order to get rid of tooth pain? So that is group which they did the injection to sphenopalatine ganglions with botulinum toxin, but they use computerized guidance with 8 patients. They find that 80% patients got 30% improvement in terms of pain control, both intensity of the pain and frequency of the pain as well. This is my studies, which is going to be published very soon. Instead of using computerized injection, which is very difficult to do, we use fluoroscopic guide injection to sphenopalatine ganglions, and we use 30 units of botulinum toxin injections to sphenopalatine ganglions. We also found the same result. Both pain score after around 2 weeks significantly reduced, and the frequency of the pain was significantly reduced as well. Most patients have pain, very tolerable, and only a few times per day or a few times per week at the end of the treatment. Then the other type, that's the nerve, right? In Korea, this is the study published in Korea. Used for CRPS treatment with sympathetic injections very well as well. After 75 units of botulinum toxin into the lumbar sympathetic ganglions, you have good pain control for up to 3 months. The durations of the botulinum toxin is actually different from the duration of muscle when you use it for cosmetic purpose. Cosmetic purpose, because they block acetylcholine, it's supposed to be blocked for 6 months. But when you use with pain, because it's also selective with like I said, special group of the pain vesicle neurotransmitter, they only block for 4 months. That's from current studies. So most of the studies stop at around 3 months to 4 months for the study of treatment, pain, and botulinum toxin. So people try to branch out the treatment. So this one they try to inject into the knees of post-total knee replacement. I don't understand how, but they did the injection into the joint which already replaced, and then they found that the pain was reduced. And then this group, they inject it into the non-replaced joint onto the arthritis joint. The pain reduction was no reduction. So for orthopedic pain, a bit skeptical. I don't think it works because it's not really a neuropathic pain. I think it's mostly somatic pain and bone pain. So still unknown. So there's a lot more study need to be done on this. So lastly, this is almost my last slide. So this is a review on Lancet long time ago, 2015. This is very intriguing to me because look at the number needed to treat. The lowest we know number needed to treat for neuropathic pain is tricyclic antidepressant, which is around 3. That's very good already. So, but for botulinum toxin, the number needed to treat is only 1.9. But this 1.9 is very, you have to choose your candidates very well. Tricyclic antidepressant can give anyone with neuropathic pain because study is very well known. There you have a lot of studies to support. But botulinum toxin studies is still limited. But you can see that number needed to treat is very low in these Lancet publications. So anyway, in summary, I think there are lots of more studies that need to be done. Currently, we know that for neuropathic pain, it works very well. You can easiest way to do is intradermal injections. Then you can try other ways of injections like treatment or